Um, what I'll do is I'll just introduce who we've got today. So first is Miss Vig, who used to be my old boss when I was an F1. She's sat on more councils than I've had hot meals, and has always been passionate about equality and diversity throughout her career. We've got Elize Clark, who's a good friend of mine. I met her whilst walking up Machu Picchu in Peru. She also happens to be a program lead for Moving Ahead, which is a global organization, an industry lead on inclusion and diversity. They work with huge companies such as Google, the Premier League. I hope you're all going to watch later when Liverpool beat Chelsea, just to name a few. Dr. Naqvi, MBE, is the current interim director of the Workplace Race to Quality Standards for the NHS as a whole. Welcome, Dr. Naqvi. And Michael Okocha is a general surgery registrar, I believe, and has an incredible Twitter handle at the Trauma Surge, and is the newly appointed ASiT Equality and Diversity Officer. So welcome, Michael.
Thank you.
Thank you all for coming. So I've got some questions, but depending on how the conversation goes, we'll just see where we get to. So, Ms. Fig, if I start with you, obviously this has been important to you. We see from Twitter, and anyone who's met you will know this, but how has it changed over your career, the issues we face with equality and diversity in surgery?
So it's interesting, Tom. I qualified in 1991, and through my childhood and growing up, all the representation of surgery and doctors and medicine was white males that spoke the Queen's English, and that wasn't me. I grew up in North Wales, and I was encouraged to be a social worker. Medicine was not the right avenue for me, apparently. Anyway, despite that, I qualified, and I was the first female Calman trainee in Wales. And at that point, there were wonderful role models, but they just didn't look like me. There were female surgeons, but they didn't look like me. Now we know that there is absolutely increasing equity and diversity within medicine and in surgery, but we're just not far enough down that line, Tom. So it's not about just colour and gender. This is about, it's interesting, one of my white male trainees asked me the other day, I'm now sitting on an equality and diversity panel. Am I just there as a token male? And the answer is no, because it's about inclusion. It's about funding of courses. We expect trainees to pay up front prior to be able to attend a course. It is about open access journals, mentors, a confidence band, the specialities. So and we also know that medicine can't be all consuming, and there are going to be portfolio careers, and people will need different time out. So we're absolutely better than where we were, but there's a long way to go, and I'm looking forward to hearing what the other speakers are going to say too. Thank you, Tom.
No, there was a really interesting talk in the presentation session I was in earlier, which commented on MRCS pass rates, and actually the focus on socio-economic issues and those from higher deprivation rate areas was a really interesting side to this. As you say, it's not just about colour and gender. Michael, I wonder, as the new Equality and Diversity Officer for ASiT, what do you see the problems facing trainees today?
I think, so the work we're going to be focusing on is can kind of broadly be broken up into issues getting into training, bullying and harassment throughout training, and then general kind of career progression. And if we just take a look at getting into training, as Ms. Vegas just said, there are significant costs associated with surgical training. And when you compare that to other medical specialties, you could spend up to 42K getting into being an oral and maxillofacial surgeon in training, or 8K for general surgery, whereas the maximums you're seeing with medicine at the higher end is about $7,000. There's statistics, especially with how we did the ST3 applications this year, where people self-evaluated. There's significant data out there, especially the recent Harvard study in June, which demonstrated that women are significantly underscoring themselves, sometimes up to 30% less than their male counterparts. And then we haven't even started looking at the BAME data. The most recent studies were in 2017, 2018. And there's a nice paper in the BMJ Leadership Journal, which essentially said that there's an attainment gap between students, and that whether we recognize that they're being discriminated against overtly or whether it's subconsciously, there is still a significant difference between what they achieve. And then when we turn on to bullying and harassment, you're looking at the Hammer It Out campaign, for example, that Simon's done incredible work on. But it's even with such a big campaign and almost everyone in the country recognizing it and understanding that there's bullying and harassment, it still goes on. And then we talk about kind of career opportunities. One thing that ASiT's doing, and one thing that I have to give massive credit to Josh is that they've created this role to basically say, look, are we, however diverse our committee are, and it is incredibly diverse. If you look at the picture Josh put up at the end of this slide, it's very diverse. But even with all these people, are we still being inclusive enough? And I think a lot of organizations are now starting to wake up to, we need an equality and diversity officer, or we need an equality and diversity policy, but people need to think about what are they actually trying to achieve in that, instead of just kind of jumping onto the bandwagon. And that's something that ASiT we're taking really seriously, and we're trying to work out what we can do at each stage.
Thanks for that, Michael. Dr. Naqvi, perhaps you could help us out here a little bit. So obviously throughout your career, this has been a focus. Is there anything that you've seen that's worked well, or hasn't worked well, or that we should be doing?
Yeah, so from my perspective, and having worked on race equality now for a number of years in the NHS, my belief is that we need to do something different in order to get a different outcome, because we know of the disproportionate gaps in terms of, if you have a look at the journey of a medic, right from the outset in terms of A levels to medical school to placements, and then working within the NHS, we know that the experiences and the opportunities are different to the white majority. And we know that through data, research, and evidence, of which we have a lot of information and a lot of research on. Now, this year I always say we've had two pandemics. One is COVID-19, and the other is people waking up to the pandemic of racism and Black Lives Matter and all of that. Now, if we are to have a differential outcome in terms of opportunities and experiences for a Black and minority ethnic workforce within the NHS, and I'm talking about not just differential attainment within medical school, and we're doing a lot of work on that with the University of Bristol, for example, but also in relation to once they're within the workplace, in terms of recruitment from shortlisting, in terms of awards that they receive, which impact upon pay and pension, in terms of going into a formal disciplinary process, and how long does that disciplinary process last, in terms of access to non-mandatory training and access to courses, etc. Not least bullying and harassment, victimization, not just from colleagues, but from public and from patients. And of course, the crucial one, which is representation at senior levels within organizations. We have over 220 NHS hospital trusts across England, and yet we only have less than 40 of those trusts where the medical directorate is being led by a BME person. And yet, despite that, 40% of all hospital doctors are from a BME background.
Yeah.
50% of all GPs are from a BME background. So we've got a lot of work to do. Yes, we are making some inroads, I have to say. And over the last 4 years, we've seen a closing down in the gaps of some of those operational interventions, indicators that I mentioned. But there's a lot more work to be done. the crucial bit for me, Thomas, is that, and as I mentioned before, we need to do things differently. So what does that mean? That means that we should not just expect our BME people to stand up and talk about their lived experience, and us for the majority to hear that experience and be passive to it. But we also need to turn that around almost 360 degrees and think about whether we can have a similar level of openness with regards to privilege. And what does it mean to have privilege, not just within our NHS, but within society as a whole?
Yeah.
So for me, it's about shifting the focus and not just being passive recipients of the discrimination that we see, but being active agents for change.
Yeah, I think that's really interesting. Is there anything you've seen over your career, a particular initiative that's been set up top down that has been shown to be beneficial?
Well, I've been leading on something called the Workforce Race Equality Standard in the NHS since 2015. We started that program, and what I can say is that those hospital trusts that are closing down those gaps, in particular the gaps in relation to culture, how it feels to work in an organisation, the questions that we often complete within the NHS staff survey around bullying and harassment and victimisation. Those organisations that tend to do well on those indicators are organisations where typically your white, middle-class, male chief executive of a hospital trust is able to stand up in front of an audience of BME people, staff, and have open and honest conversations around race and racism without being worried about saying the wrong thing or getting tongue-tied or but being on that journey of reciprocal learning. So the message, I guess, is we need more openness. We need to discuss these issues in a more open way. And Black Lives Matter has kind of opened the door for us to some extent. Probably not open, probably unlocked the door. Is there yet to be open, I think, but it's definitely unlocked the door. But there is a lot more work to be done to have those open and transparent conversations around race, racism, and privilege.
Yeah, I mean, that has to be the most important point, doesn't it? That it's not necessarily about being wrong, right, or the other. It's about being in the conversation. Elize, maybe you can help us further, because you're not even a medic and you're here at a surgical conference. Thank you so much. It's going to be really interesting to hear what you've got to say. I just wondered, these things that we see are obviously part of a wider problem. Do you see any similarities between other organizations you've worked with?
Yeah, definitely. I think, from the work that I've been doing, I've had the privilege of seeing different industries and different organizations. And through all the work that I've done over the years, I see that the problems are amplified in different ways. And actually, different sectors are saying they're struggling or they're challenged in various ways. But these challenges are usually consistent across them. So, I'm thinking about things like some of the things that have been mentioned today, but also around culture, behaviors, how do we improve representation, looking at the retention of, high performing underrepresented groups, and actually trying to drive that engagement and inclusion by trying to create that great place to work for all employees. And I think just around Michael's point around the high stress environment and actually, how does that play out? I think sometimes stress is good. Obviously it gets things done. It can improve performance, but actually there's always that tipping point. And I believe, that can play out in the way that people are behaving and, their behaviors. And I was actually recently reading something that, when we have limited mental resources available or we're under stress, we rely more on stereotypes for our judgments, and that helps, to guide our responses. And so actually in all of this environment, when demands are so high, these demands can enhance stress, whether that's at work or at home. And I think we really need to think about and consider the space and time that we give to ourselves. The pressure's there, it's always going to be there. And we're always in this always on culture. So, how do we really create and give ourselves the permission to pause? We all need to think about how we create those better moments and better thinking. And that will enable us to then have better conversations and more valuable conversations as well.
Yeah, absolutely. And with that point, do we see in other organizations which might be considered highly stressful, or are they more prone to inequality or bullying that we might see in medicine and surgery?
Yeah, I think, just to my point that, actually we're finding that stresses are around us, whether we are at work, we are at home, and people are experiencing those different stresses. And I think it's how we manage that, and how, we actually do stop for a second and think, okay, what is this stress doing to me, and how can I actually do something about that? So it's just being really deliberate and actually saying, yeah, I need to think about how my stress is like supporting my behaviors in certain ways. So I think, I think across so many different industries, there are different stresses. And I'm seeing that, whether I'm working with people in sport, people within financial services, healthcare, whatever that looks like, I think there are always going to be different stresses. So it's looking at how we manage that. And I think actually just from organizations, what they are actually doing themselves, I think they're really noticing how a lot of this conversation and this work can trigger a lot of emotions. So they're actually thinking about their well-being support and their offerings. And, we're seeing how organizations are looking towards some of their more employee-led networks as a platform to discuss some of these specific challenges. So it enables people to have those conversations. And what we're finding at Moving Ahead, and one of our kind of main offerings is around mentoring, because we find that actually, whatever your background, whatever your level of experience, mentoring can be so powerful, whether that's for your personal or your professional development. And for us, we find that it's connecting people and they're having those different perspectives. And I think it really gives, going back to that space piece, it really gives you that dedicated time, that space to have these conversations and to support your thinking, to reflect. Yeah.
And with other organizations, is there anything specific that you're doing that are helping to tackle these problems? I know you've mentioned mentoring. Anything else that we should be looking at and trying to adopt, either locally on a small level or from top down?
Yeah, I think we're working with different organizations and seeing different things play out. And, actually a lot of organizations are saying now that we've done a lot of listening. So, they might have listening circles within, different groups, trying to understand, people's lived experiences and things like that. But actually, what's the action now? What action can we be taking? And trying to be really intentional with that. So, some organizations are thinking about how they support certain individuals. So they support their Black colleagues, for example, and what do they, what would help them, and what are the kind of systems that are currently in place that might be holding them back. So I think it's trying to really step back, look at what is there, and then, actually think about that strategy going forwards.
Okay, thanks for that, Elize. Just back to yourself, Dr. Naqvi. What is being done for the NHS as a whole, as a wider response to this issue?
Well, this issue is complex. It's an issue that hasn't just been around since the beginning of the NHS in 1948, but it's been around within our society for centuries.
Yeah.
And society has been designed perfectly to give us exactly what we've got. And yes, we can tinker around with HR policy and process. We can, have one extra BME person on our boards, or, two less BME people going through the disciplinary processes that we have, and we will see a shift in our numbers overnight. That's, and that's fantastic. But we need to shift people's minds and hearts around this agenda. And in order to change culture, it takes time. And I always say in relation to culture is think Mo Farah and not Usain Bolt, because it's not a sprint, it's more of a marathon. And we've seen that in our data. In fact, we're closing down operational interventions, but the culture within the NHS and the data around that to date has remained static in terms of bullying and harassment, in terms of victimization. And I have to say, for both PME and for white staff. And that's something around, as colleagues have mentioned just now, around the level of pressure within the NHS, but acutely so for BME staff, because that pressure is there, but it's differential in terms of the way that is kind of experienced between different parts of the workforce based upon ethnicity. So we need to kind of focus on yes, transforming the policies, but shifting and transforming culture, and both are two sides of the same coin. So we need to kind of focus in a persistent way in relation to both. So with the Workforce Race Equality Standard, for example, we're very early on. So I mean, what we often do in the NHS and at the Department of Health is warm up the system to any new policy. But for the first time in the history of the NHS, the standard went into the NHS standard contract. It went into CQC's regulation of hospitals, and within various other frameworks, so that people and organizations had to do it, which is wonderful. But of course, we want to be in a position where people focus on the agenda because they want to, and not just because they have to as a result of regulation, assurance, or contract. And so that helps. Of course it does. We also need to kind of shift people's and those deep-rooted cultures that we have within our organization. So there's something about going back to those honest conversations, something about being open, being more inclusive around our behaviors, and really understanding what does that mean for us collectively and individually at the same time as well.
Yeah, fantastic. Ms. Vig, just carrying on from what Dr. Naqvi has said, is there anything that the Royal College of Surgeons or the JCST are doing to provide the support to allow us to make these changes, both to our culture and providing some of these policy changes and support?
So I think before I answer the conversation about JCST and the Royal College of Surgeons, what Habib has just talked about is not going to happen if it's a top-down approach. Yeah. So it's got to be top-down and bottom-up. It's got to be everyone being responsible for this. So we talk about surgeons being bullied and harassed, but actually our BAME colleagues who are nurses find it incredibly difficult managing patients within the diversity of the community, which is the UK, because Elize, as you talk about stress, stress plays out in terms of stereotypes, and we all go back to our roots. And we go back to the way that we brought up as children, the way our cultural norm was in the wherever we've lived, and we all then look at that through the lens of our culture that we've been brought up in. So, when people are stressed at work, when something is happening, that inclusivity can only be when we get rid of our unconscious bias. We have to have that equal platform every single day we go into work. So, Michael, you talk about Simon's campaign, cut it out, hammer it out. We need to call it out every single day, not just the medics, but this is for the professional body inside and out of work. This is how we should be living our lives. This is integrity. But also the unconscious bias, which is that we go off in a huddle, or we go to the pub for a drink, or we ignore the person who's wearing the hijab. All of this now needs to stop. And for the people on the call today, most of whom are trainees, you are the leaders who can make this happen. Please do not wait for big diktats to come from above. It has to happen. And for me, this year, every single trainee in London, because I'm the core TPD, as you know, Tom, and we work together with the other TPDs, every single core trainee will do an unconscious bias training. It has to come in. It has to be something we just don't have lip service to and have a tick box to. So what are the college doing? Well, the college have a diversity review being led by Baroness Kennedy, because we are now led by 4 white males who are unbelievably diverse in the background. But the picture we see are 4 white males. And JCST now are beginning to realise, along with HPE, that cultural norm that plays into exams and exam results, confidence on the shop floor, filling out portfolios and progressing in our careers, never mind trying to get into medicine in the first place, all of that now needs to change. But as Habib says, that's not going to happen overnight. This is going to be a generational change. But the question is, how do we push it further? And I think that has to come from all of us individually. We have to take responsibility as well.
And Elize and Michael, what are those individual things that we can be doing? Perhaps Elize, you can kick us off. What is there something that you, when you're working with an organization, when someone asks you, what can I do personally? What is the response? How can you help those people?
Yeah, I mean, there are so many things, and I think that the main kind of three things that come to mind are around, how do you be respectfully curious? So, how do you hold space for your colleagues, your friends, people around you to share, well, if they want to share, and actually, how do you actively listen to what they say? Have the conversations. I think if people don't do this, it might feel uncomfortable. It's going to feel uncomfortable for them. But actually, if you are nervous that you're going to get something wrong, but it's better than there being inaction. And so I think it's about how do we educate ourselves. And one thing I would say with that is that it's not for the marginalized group to actually teach the majority. I think the majority should also be self-educating themselves, and actually how do they do their own research too. So I think, we all have to take that responsibility. And as Ms. Vig said, it's for all of us to do. It's not for someone to say you should do this. It's a collective. I also think, if you see something, say something. So how do you show up for people around you? And, that is when you're going to make a big impact. So if you see something that doesn't feel right, or you see someone being mistreated, we've talked about bullying today, speak up, and actually take that action. And it's easier to say that, but it's like trying to find those people around you that you can speak to about it and share and, just have those conversations. I think the last thing I would say is, how do we champion each other? So actually amplifying the voices and experiences of people that are around us, underrepresented groups that are around us. So this could be looking at who you promote, even via your social media, like where you buy your products from, whatever that is. But it's how do you positively advocate for others and actually leverage the power that you've got as yourself to do that. So I think it's for all of us, whoever you are. It's just thinking about how we continuously train those inclusion muscles. That's the way I kind of look at it.
That's such a great answer. Michael, I wonder, just from a personal point of view, and just carrying on from Elize saying about trying to call these things out, how as a trainee can we do that? Because sometimes it can feel quite uncomfortable, especially if it's a boss or another consultant or registrar who's more senior than us, who's the perpetrator.
So Prof. Brennan gives this amazing talk on human factors and how they interplay in the theatre environment. And one of the things that comes out of that is honesty always penetrates. So, I could be scrubbed with a boss and he could be doing something and I say, I don't really feel comfortable. I don't understand what we're doing here. And that's really hard to ignore. And it's the same in your interaction. So if you feel that, a boss is being particularly harsh to a scrub nurse, or something's going on and a patient's being treated unfairly, or they don't quite understand what's going on, the boss is kind of brushing over it, you can say, I don't feel comfortable with a situation. And I think we need to do X, Y, Z to remedy it. And that's really, really hard to ignore. The worst thing you can do is just kind of bottle it up and not say anything. It doesn't help in the long run. It doesn't help the boss see it from a different perspective. And I shared my story online a couple of months ago, and I had lots of responses. But one of the things that really hit me was one of the bosses called me, and he said, look, if there's anything that I can do differently, is anything that we need to learn from it, just tell us. And I think that if you have had an experience that has left you feeling unsettled, and you've got someone like that who is open to the conversation, that could be a way into changing all the consultants, because he's now gone away, and I know all the consultants have seen my posts. They've seen everything I wrote. I had other messages from consultants who don't even use Twitter, so, it does have an impact. So, yeah. Yeah.
No, thanks for that. I think that's really interesting. Any final comments before I just address some questions from the viewers?
I wanted to talk about some of the things we're planning on doing with ASiT. Go
for it.
So one thing, after we kind of take a look at our own internal process and make sure that we're doing the most we can, we want to get a survey out to all trainees. And it's not just for people of color, it's not just looking at gender, but if there's any discrimination. I've had people reach out to me on Twitter who are surgical trainees in their late 40s who are just getting into early reg training, and they feel discriminated against because they're older than some of their consultants in some cases. I think it's really important that everyone fills this in, and it's not just asking about discrimination you've experienced, it's also about discrimination you've seen, and that'll be coming hopefully towards the end of the year once we've had things approved. And then we're going to do a campaign and try and work out how best it is to report these things, how best it is to start a conversation. And at that point, we'll be asking for people who filled out the survey to give us ideas as to how they want things addressed. So another thing that we'd really love everyone to be involved in. And then sometime next year, we're going to be starting something called the 50 Faces of Surgery. And it's like the 50 Shades of Grey, but just less sexier. And all we want is we're gonna really demonstrate that representation matters. And there's so many trainees out there who say, I don't have a mentor who looks like me or thinks like me or has come through what I've come through. And we're going to say, look, here, this is a 20-minute, 10-minute video of someone who's willing to be reached out to, who understands, that background, understands some of the struggles you face, and is willing to share their experiences. So those are some really exciting things that I'm ASiT planning, and we're cooking up, and it's going to be great. Okay,
thanks, Michael. Any other comments, or shall I go to the questions? Okay, so from Taz, New Zealand has a national positive discrimination policy with people from Maori and minority background requiring lower entrance grade to university for medicine to accommodate for the social inequality that can limit them. Should the UK introduce a similar policy? Anyone want to say that?
Yeah, I'm happy to make a start on that one. So this one is interesting to me because I think we don't want to be looking at these quick fixes. It's actually what is limiting these individuals back. So it's actually going back to that and really trying to understand what that is. And I think rather than trying to say, right, okay, let's go with this policy because it feels like the right thing to do to get people in quickly, actually what's the limit for those individuals, and trying to really understand that before saying that we should put these policies in place.
I would agree with that. Any policy should focus on the root cause of the problem. And if we're frank about this agenda, then we need to look at structural issues. We need to look at issues such as racism. In February of this year, I was part of the team that put together the Racism in Medicine special edition of the BMJ. And at the launch of that special edition in February, my boss, Sir Simon Stevens, announced that we will be launching and establishing the NHS Race and Health Observatory, which will be looking at a number of things, not least looking at the root causes of the issues that we've got. So if you look at the example that you've just given of New Zealand, which is an interesting one, because the issue isn't around PME people being less intelligent, which that policy is kind of aiming at. So we get lower grade from those people because they're less intelligent. The issue is that perhaps the structure of the exams, the questions, the way they're given, or the lecturers, etc., are not as diverse or as culturally sensitive as they should be. So we need to look at the root causes and not just a superficial kind of putting a tape on the cracks that we've got, which are kind of deep.
Yeah, that's really interesting. Just for the interest of time, we'll move on to the next question. Perhaps, Ms. Vig, you can start us off on that one. So from Josh, thanks, Josh. Many of the requirements for accessing postgraduate training fail to acknowledge the inequalities already present in the CVs of applicants. How can organizations break this chain in a way that does not create a new preferential selection bias? There's some similarities to the previous question. And how can trainees who might not be negatively affected by these inequalities help to tackle the issue?
Tom, so I'm not going to answer that in the totality of the surgical specialty, but let me just pick on research.
Yeah.
So research is a great example. If you are from a background where research or academia is something that's discussed in your household, if it is something that your peers and your senior colleagues have encouraged you into, if you have the funding to pay for open access journals, you will naturally do well in research. If you have time aside to do these things, this will happen. So do we change our research profiles for specialty selection to a collaborative arena, so actually everyone has the ability to develop that at a steady pace throughout their training pathway, rather than coming into it with privilege from whatever background, but the privilege that exists because you are from an academic background. So, or you've been to the right college or the right medical school that encourages that. So I think what we need to do is as Habib and Elize have said, we need to go back into not just fixing the top end, but also looking at the bottom end. How do we become more inclusive? So actually our trainees coming through, the medical students coming through can attain what they want. And what we don't have is burnout and dropout because people are so fed up of trying to fight the system. And that's what's happening at the moment. And that doesn't just apply in medicine. It is across the profession.
No, I mean, that's, I couldn't have said it better. Michael, can you add anything to that, or as Miss Vig thought it?
As always, Miss Vig is right.
Sorry, Michael.
Please don't make me follow her.
No.
But no, I can answer the second bit of Josh's question. If you see it happening at work, if someone has been at the, I can tell you about almost every female in the room has been called a nurse at some point.
Yeah.
And I can tell you that I can count on my hands the number of times I've intervened. And I've seen it happen. And I've just, laughed about it afterwards. If you see it happen, that is your opportunity to be like, no, this is Dr. So-and-so. Mm. That's your opportunity to make their day that much better. And I think it's a mindset that's really hard because we're busy and everyone's got so much to take on. It's a mindset that's really hard to have. But if you start getting into the habit of it, just stopping those processes, the poor registrar who gets stuck trying to consent a patient is asked 1 million times where he's from, even though he's already answered London. You can end that right there. You can be like, I'm really sorry, can we finish the process? That's your power right there in that situation. That's all I can say to that, is that there are opportunities throughout the day to make an impact, and we should be taking those up.
It's great seeing Miss Vig ask that question, and when the patient who's asked her where she's from, when she says Bangor, North Wales, seeing their response, it is fantastic. There's a quick last question actually here that Michael, you can maybe help with. I'll summarize it. Basically, as a trainee who's a Muslim or is Islamic, the one mode for socializing and networking is drinking alcohol or going to a pub or whatever else. Is there anything that can be done to tackle this between alcohol consumption and non-alcohol consuming colleagues?
It's a big challenge, and it is going back to what Dr. Naqvi said about the culture.
Yeah.
And I think we need to address departmental cultures and say, look, instead of the pub, why don't we go to this restaurant that also has options for everyone?
Yeah.
And I think it's starting to look at how we can be more inclusive in our social aspects of surgical society. So it is a challenge, but I think part of the campaign that we'll be doing from ASiT is about trying to tackle those issues.
Yeah. Okay, well, thank you all for joining. That ends that session, which I personally found really inspiring, and I hope everyone's taken something from it.